Hello, everyone, and welcome to Garfunkel Wild's 10th annual ASC and Healthcare Management Symposium. So the next 30 minutes, we're going to discuss transaction considerations for physicians. And my name is Kimberly Kempton-Serra. I'm a partner at Garfunkel Wild. I primarily work with ambulatory surgery centers, all different types of healthcare providers, on a transactional and regulatory basis. I'm joined by two industry experts, Scott Davis and Bob Goettling, who is a veteran panelist of our seminars. So thank you for coming back. And Scott, thank you for joining us for the first time. Since it is your first time, why don't you go ahead and tell everyone a little bit about yourself, and then we can hear from Bob.
Great, and thank you for having me, Kim. Really looking forward to the opportunity. As noted, my name is Scott Davis. I'm a managing director at Provident Healthcare Partners. Provident is an investment bank that, as our name suggests, focuses exclusively on healthcare services. So we've been operating for about 25 years in the same capacity, and that is assisting the owners and operators of healthcare services businesses navigate the transactional dynamics that come with doing a deal. We've generally followed the ebbs and flows of consolidation within healthcare over that time frame. And most important for today's conversation is our heavy weighting towards physician practice and multi-site provider business transactions, where we've been largely focused for about the past decade. We've done north of 100 transactions in that capacity and across really all the different subspecialties where consolidation has happened to a great extent, and also those where it's just starting to get off the ground. We do operate within the lower middle market, many times working with founder-owned businesses or those who have not yet gone through a transaction, and very adept at working with physicians, or at least those who have not been through a transaction, the educational components that come with it, and really ushering groups of all form and fashion through what can be a pretty dynamic and lengthy process. So again, appreciate your time here today, and thanks for having me join.
Thank you. We're happy to have you. Bob?
I'm Bob Goettling. I oversee all of transaction services for the Bloom organization. Like Provident, Bloom organization is an investment banking firm, but we almost exclusively focus on physicians and physician practices, advising them on monetization opportunities or just growth or even strategic matters. Myself, I've been in what I call the doctor business for over 30 years. Actually started back in the 90s as one of the founders of one of the first practice management companies for physician practice management. For those of you who were around back then, you know that first round back in the 90s didn't work very well.
I was in high school.
Yeah, I ran development for 12 years, and then ever since have been on the side of actually representing physicians and helping to advise them on mostly their practice transactions, but also surgery centers and other ancillary businesses that are typically physician owned.
Great. So you sound like perfect for this presentation, obviously. So we don't have a lot of time, so let's just jump right in. What can you both tell us about just a general overview of the current market and some trends that you're seeing? Whoever wants to go first, that's fine.
Sure, I can start, Bob, if you want to follow up after me. I kind of think about it from a macro and a micro perspective. I think at the macro, obviously, everyone is aware of some volatility in the market, and in particular, the increase to interest rates. And that certainly has an impact in the M&A environment. I think, the majority of the folks who are probably going to be participating in these discussions would reside in what I referred to earlier as kind of the lower middle market of potential transaction size. And I'm happy to say, and that's where we operate at Provident for the most part, it has been relatively sheltered, I would say, from some of those kind of negative impacts. That's not to say it's entirely sheltered. From our perspective, I can just speak to the deal flow and work that we do. We've seen probably less activity of the largest of practices, as well as less activity from private equity investors in particular, looking to exit some of their existing portfolio holdings. And that's been the case probably over the last 12 to 18 months. Rationale there being, access to capital to fund what could be a middle market level transaction, or certainly a middle market deal for a successful private equity exit, is a little tougher to come by. Again, as I alluded to, the lower middle market, where deals that are getting done for the first time, potentially add-on acquisitions to larger platforms, those are still actually happening at a pretty precipitous rate. We're seeing transactions get done at the same relative rate as in the past, albeit a little bit differently. We're seeing an increased amount of scrutiny from those lenders that I alluded to before. So what was something of a commodity leverage at one point in time is definitely something that's harder to come by, and therefore, there's additional, potential diligence hurdles and therefore length to a diligence process to complete some of those deals. So I would say that's one of the negative impacts. But all in all, I can speak for Provident. We're closing in on what for us is an average year, I would say, in terms of production. So negative macro impacts have not led to a drop off in our workflow at all. We're still getting transactions done at the same premium valuations and with the same regularity that we did prior to that 12-18 month stretch I alluded to. At the micro level, I would say that we're seeing some impacts, debt rates aside, of margin compression for some of these businesses on the physician practice side, groups that may be routinely in that 15 to 20% EBITDA margin range being squeezed to call it 13 to 18 or 12 to 17 on average. Rationale there being a few things, just relative increase of costs, particularly for supplies, things like a tough labor environment, the cost for hourly rates of administrative individuals, the retention of those individuals, and kind of complexities that come with operating business when that retention is not as high. Benefits costs, certainly healthcare insurance and the like, going up. So that has had some impact on businesses. Investors are aware of that. They're mindful of that. They're seeing the same thing in their own platforms. So it's not, again, preventing deals from getting done or making businesses look any less attractive per se. It's just something we're mindful of as we compare to, say, prior years and some of the financial metrics that went alongside those. And the last thing I'll note is that we're actually seeing a little relent in some of that margin compression, even over the last, call it 3 to 6 months, as labor markets are beginning to stabilize a bit. People are getting their hands around this new operating environment and finding other efficiencies kind of drive that margin where it used to be historically. So
thanks. So Bob, do you see different models being more likely to occur because of the environment right now, or is the model kind of staying the same but acknowledging some of these pressures?
Yeah, I would, yeah, absolutely, Kim. I would agree with everything Scott said from the perspective of the market. With physician practices, all the points he raised, are exactly from what we're seeing, spot on. But again, the most important, he noted that they are still very busy. There's still a lot of deals getting done. We're seeing the same thing. But to your particular question about, I think common sense would tell you, with interest rates going up, with costs of everything going up, the private equity buyers, right, have a little bit, they're probably slowing off on the number of deals that they're doing and valuations. But what we're seeing is that as this evolution continues on, and the evolution of consolidation, physician consolidation, clearly it is different than back in the 90s when it happened, and it was all put it together, go public, everybody cheer for the stock to go up. It's a different animal now. It's really based this time around on value creation. And as such, the private equity, they led the feeding frenzy of consolidating practices and physicians and in a whole bunch of different specialties. Now that's evolving to if you want to call it the second phase or the third phase of more sophisticated types of consolidations. And it's not just private equity. Of course, the private equity deals get a lot and in the news get a lot of the coverage, but there's other models. There's there's minority-owned MSOs. There's health systems. There's the insurance companies. There's what we're seeing now, and have been seeing for a couple of years, that I happen to believe is going to be the future on it. Is you're going to have hybrid models. Where I think anybody, whether it be a health system, whether it be a private equity firm, whether it be a physician group, whoever can bring value to the consolidation will have a seat at the table. And I think it's going to be, for guys like Scott and myself who put these deals together, it's a great time for us because as this continues to evolve, the sophistication on the different models is going to rise to a higher level, which again, all in the effort of creating value. But I think it's going to, I think the business, is not, regardless of what happens with interest rates and inflation, is not going to slow down or stop.
Great. It sounds like everyone's going to need some really good healthcare lawyers, though, going forward.
Exactly. No, and Kim, but hold on, Kim. Let me even respond to that because it's not only and I'm sure Scott can give you the same horror story experiences. Even when they, before things it got this sophisticated or this complicated on doing transactions, physicians and physician groups that don't get the best counsel. I'm talking about legal counsel, financial counsel, all of that. They are open to A, making mistakes, or B, most importantly, missing something. And from what I see nowadays, whenever I run into doctors who did a deal, a year ago, 2 years ago, 5 years ago, and they say they are unhappy, and I dig into it, it's always because either their legal counsel, who was the brother-in-law, who was the divorce attorney, had no idea what they were doing, or they didn't have the right advisors around. And as things continue to get more complicated, that is absolutely paramount. And it's paramount to folks like you and Andrew, and Scott, and those of us who this is all we do. I think it's very important to have that kind of counsel.
Yeah, I agree. Okay, so one of the things that physician clients who I deal with, a big concern they have is, well, how much money am I going to make going forward, right? So there's usually some, big pile of cash up front, and then, many of them want to keep working for 15, 20 years. Some of them want to retire, but what should doctors be considering in terms of how will they make money after a transaction? And I guess, Scott, we'll come back to you first.
Sure. Yeah. I think Bob and I can kind of cover this one in tandem. We really think about it as three major components of value. You've got, within a transaction, your cash at close component. You've got your go forward compensation, as you alluded to, Kim, and then you've got your equity component, which will be referred to as a rollover equity into the platform. And so, on the front end, and taking a step back here, a physician practice typically is, a no net income business, right? Because it's a partner track model. At the end of the year, they take out the profits as distributions, as they should. And so on the surface, when you look at these businesses, they're not profitable. Now, of course, if you peel it back a little bit further, what you're going to see is these physician partners are making ideally good requisite income for their particular subspecialty and level of tenure through traditional W-2 compensation. But above and beyond that would be the profits of the business they're taking in the form of distribution. So that technically has them earning more than their peers who aren't owners in a similar type of business. And so in order to monetize the equity of a physician practice, you have to create profits that you can, market to investors and put a multiple on and create that value everyone's looking for. So the way you do that is through a process called compensation normalization. So just very rough numbers and keeping it easy. If a physician, a partner in a practice, is making $1 million, including your W-2 and your distributions, but that subspecialty and that local geography calls for that physician on average to be making, say, $700,000, well, there's $300,000 conceptually of excess income that could be monetized through EBITDA. Let's say it's a 10 partner practice, same ownership and distributions for everyone. That's $300,000 times 10 individuals. That's $3 million of EBITDA that could be marketed to investors. Now, there'll be other things that are added into EBITDA, the definitional things like interest, taxes, depreciation. There'll be other adjustments for one-time non-recurring expenses, personal expenses, pro forma adjustments, a whole bunch of other stuff we could spend time on. But point being, you're going to have a lump sum of EBITDA that's largely created through a compensation adjustment by these physicians. Again, that's marketed to investors. You're going to get a multiple applied to it. The multiple times the EBITDA will create your enterprise value. That enterprise value is then going to be split between cash proceeds at close and that rollover equity component that I mentioned before, which I'll leave to Bob to speak to in a second. Usually the mix between those two things for a physician deal is going to be, call it 60 to 80% cash, 20 to 40% rollover equity. And really important to note that those aren't just, the nice to have type of numbers for most of our clients. It's a requirement at some level. Kim, you alluded to the physicians wanting to continue to work. In a physician model, they kind of have to continue to work at large. Certainly, there could be retirements at close for certain folks. There could be requirements years 1, 2, 3, 4 in the future. Goes without saying. But the model is predicated on individuals producing and seeing patients and driving revenue. So that needs to happen by and large for the group. And so it's important to make sure that comp is adjusted correctly, which is something we specialize in, as does Bob and his team. That the value at the enterprise level value is fair and requisite for your type of business and the profile of your business. And then that equity component is in a safe place and could return great outcome in the future, which, Bob, I can turn it over to you to kind of talk about those dynamics.
Sure, and great, Scott. That was a very good, overview of all of it. And I like to refer to it as Scott said at the beginning. There in a transaction, and I always tell this to physicians, that there are three, as he alluded to, the three parts of the economics of a transaction. I call it the three-legged stool of it. The money up front, which again is obviously very important. The second piece, which is their compensation going forward, because this is not a retirement vehicle. This is not for just a way to sell your practice to move down to Florida. It is to keep going and to grow it. So the ongoing physician compensation, very important. And then the third piece being obviously the equity component, or like I like to say, the Apple or investing in Apple or Microsoft, right? And so specifically on that third one, very often we'll get physicians, and again, I do as Scott did also, you have to overview all three of them, because physicians will come in sometimes and say, and they will only be focused on the first leg. How much money? How much money am I getting in cash at closing, right? Which is a mistake, because you can't just focus on that and not on those other two elements. Vice versa, a lot of times physicians will not. They'll focus on the cash up front or the equity. And again, the equity being, there's two components of that. There's the component of which you and your partners on the practice are going to really try to take it to the next level and help, remember, as I said earlier, create value, which is going to help that value of that equity go up and appreciate. But the second part of it is that the company is going to get bigger than your partners and the individual practice at the ground level. And so you're going to want to be really betting on a team that's going to be able to produce, the growth all over. And hence the picking the Apple stock or the Microsoft stock or the Tesla stock to appreciate. And all three of those components are very important. What we're seeing on that third one, that again gets a lot of the press coverage and everything, the equity component, it's still pretty early in the phase of these private equity deals. There are several of them, many of them, I guess, that have done over 5 years. It's typically a 5-year run for them before they want to sell, and you get the opportunity to monetize on some of that equity. And while that's just, we're just getting to the point where there's more of those coming out, make no mistake about it, there will be a lot of these platforms in all different specialties that will never make it to a second bite. They will, and again, they'll have a lot of reasons, and they'll put blame a lot of places. The bottom line, though, is that they just weren't able to create the value that's necessary to be able to sell them.
So that's really you're kind of talking about a very specific type of transaction, right? Both of you, where there's a private equity firm that has a platform, and you're bringing in the doctors onto the platform. But just not every transaction is that one, right? That's probably one of the most common that's happening right now. But, I still think the general notion of doctors should be considering what they're getting up front, and they really need to consider what they're getting after the closing, right? Because when they are making half the amount of money on an annual basis, sometimes they get upset about that going forward. So it's depending, regardless of the type of transaction, the ability for income repair should definitely be a major consideration. I think is kind of the message you're both saying.
Yeah, and Kim, I can give a quick example back in the, in my prior life in the 90s when this first round of physician practice consolidation started, it was a totally different model. And the doctors were all betting on, they were selling to these companies that were publicly traded, their stocks were going to the moon. And so these physicians, this gets back to what you were just saying, the physicians said, hey, pay me, I was making $1 million a year doctoring, pay me 100 grand. And then I'll take the other 900 grand in stock that's going to the moon, and I'm going to be rich. That was okay for a while till the stock went into the toilet. And then that same doc is, what are you talking about? I'm not working. I'm not doing anything. I'm not even coming to work for 100 grand, right? And so that was why it all blew up. So when you say to the point of some of them even taking a comp hit of 50% to monetize, as Scott had walked through on that earlier example there's a this time around, there's a huge amount of sensitivity to not allowing them to take take a hit that puts them below what the market compensation rate would be. Right. And I think there's a huge sensitivity. I mean, Scott, you can tell what you're seeing. There's a huge sensitivity from the buyers, whether it be the private equity, health systems, or anybody else, to make sure that that the physicians don't get, don't scrape, which is the word of taking part of the income, that you don't scrape too much.
Yeah, I will jump in just quickly on that. The reason why I use an example of, say, $1 million of income reduced to $700,000, that implied 30% scrape, as Bob alluded to. That was intentional on my part. And the reason is because that's an average of what we're seeing in these physician practice transactions. Now, it changes from subspecialty to subspecialty. For example, if we're talking about oncology, it's 20% is the going rate, sometimes 25%. If we're talking about cardiology, which is a newer kind of subspecialty of consolidation, we've seen north of 40%. And some groups and investors get comfortable with that. But on average, we're talking about a 25 to 35% range is pretty much what carries today. And this is the model that pretty much all new physician practice roll-up models are going by. And really quickly on the income repair, just to define that, I think, for our listeners, to put a point on that, the $700,000 in my example is your post-close compensation. Ideally, you're coupling that with the opportunity of a lot of cash at close, like I noted, really good rollover equity opportunities, Bob noted, but also the ability to go from that $700,000 up to a higher number, ideally back where you were, pre-transaction. That's really the home run scenario. With great cash at close, longer term, you're right back where you were from an earnings perspective on compensation, and you've got some great rollover opportunity. And the way you can do that is through the right partnership. So easy examples are like, day one post-close, I joined a partnership with better payer rates. Well, plug my work into a higher payer rate, my income goes up immediately. Group purchasing power, I get supplies at a cheaper rate. Things like this, efficiencies and growth opportunities that I wouldn't have as a solo practice, but I get through my partnership. That increases my equity value for sure, but also my yearly income.
Yeah, got it. And actually, I think that's a good segue into the boring part of this, which is increased government oversight. So what comes across my desk very frequently are bills or laws that have been proposed or adopted that affect these types of transactions. There's a couple in particular that I think we should talk about. One is there's several states, it's kind of a trend, requiring a notice be provided of a transaction, of a private transaction, which typically would not really be under a Department of Health type construct, because we're not necessarily dealing with a licensed facility. The most recent and controversial, I'll say, is the New York requirement to notify the Department of Health of what they're calling material transactions. So it was put into effect October 1st. There was no real guidance as to how to comply with the law, but it raises a lot of concerns as to, when do you submit the notice? What do you have to include? Are you going to be, giving confidential information that's then going to be posted on the Department of Health website? I think a lot of buyers are a little skittish about giving these notices. And I don't know if that's anything that you've come across. New York's not the only one. There's also a Connecticut law, and I think some others are in progress. But I don't know, I don't know if buyers are finding an issue with having to make these kinds of disclosures. It remains to be seen. It's very, very new. But certainly a consideration for doing a transaction, whether you're on the buy side or the sell side, are these types of legal requirements. The second one is restrictive covenants. So there's a proposed law in New York, and there are other states that have similar laws that would basically prohibit restrictive covenants on physicians. This is still a proposal. No one knows how it's gonna come out, but it could have a potential really damaging effect on buyers' willingness to go forward. I know, Bob, you had mentioned that, well, how could it possibly prohibit a restrictive covenant in a transaction, in a purchase transaction? It can't possibly mean that, right? No one would do a transaction, right? So we have to see where things shake out, but it's certainly, on people's radar. And I don't know if there are things happening sort of in anticipation of that problematic requirement for buyers. I don't know if you have seen any kind of structural changes to deals or.
Well, yeah, I'll give you my 2 cents on it, because it is interesting. I use the word interesting, as to, in New York is always, it seems like, on the forefront when there is anything that appears to be going, after the corporate practice of medicine, right? Or trying to hold any other business rules that apply to everyone else to physicians, right? I think that from what I'm seeing and what with my crystal ball looking into the future, the sophistication on putting together delivery systems that really do create value and reduce the cost of care, they're getting and will continue to get more sophisticated. So playing by, as Kim, as as ASC deals over the last 20 years, they got more sophisticated, and in certain states, the state governments would make it more, whether it was disclosure prohibitions, make it more difficult, to do business. But where the consolidators can still create value, they abide by them, and they mold and evolve their models so that they can comply. And I don't think that's going to change. Even on the restrictive covenant, if that goes crazy and goes state by state. But the last thing I'll say on that, over the year, over all the years, the one thing that's always interesting about the state of Texas from a restrictive covenant perspective, anytime you did a deal in the state of Texas, you always had, in the restrictive covenants, there was always a way, you had to have a way for the doc to pay X amount of dollars and he could get out of it. That was always good. It was set very high. Yeah. But it wasn't handcuffs that would prohibit somebody from practicing. It was just a threshold to make sure, if you're not happy in what you're doing right now, it's what's going to cost you to get out of it.
Yeah. So it's interesting you brought up Texas, because my last point is, and this is very fresh in the healthcare regulatory industry, is the FTC bringing a lawsuit against Carson and
Welsh Carson,
United Anesthesia Partners, for basically rolling up a bunch of anesthesia practices, which is a lot of what we see every day, and jointly negotiating and doing all of those things that would create value in what you were talking about, right? And nonetheless getting sued for potentially, anti-competitive conduct. So that'll be very interesting to watch. And I hope that bad facts don't make bad law, or it will potentially interfere with a lot of the types of deals we do. So I'm sorry to cut this off, but we are out of time. Thank you for everyone for participating. If you have any questions, join us later this afternoon for our Q&A. And of course, feel free to reach out to any of us directly. Our contact information is on our agenda and on the website. Thank you.